So this is an 81-year-old gentleman with clearly very severe aortic stenosis, quite symptomatic with heart failure and left ventricular dysfunction, moderate pulmonary hypertension, some coronary disease, a history of bladder CA, COPD, et cetera, and was deemed not to be a very reasonable surgical candidate. Was admitted with acute heart failure. Here's his parasternal long, moderate LV dysfunction, peak and mean gradients across the valve of 102 and 65, valve area of 0.5, moderate MR, and some RV dysfunction as well. Seemed like a reasonable thing to do. Here's coronary angiograms. Probably project a little bit small, but he's got a little bit of left main disease, but nothing to write home about. There's a patent stent in his proximal circ, and sort of a codominant system here. Fairly large distal circ. CT scan, his area was 463 in the sizing range of a 26 millimeter S3, which is what we had planned, and fairly deep sinuses, 31, 30, and 29. Coronary height's okay, left coronary 15, right coronary 17 and change. If you look again though, even though it's 15 on the left, he's got this snowball of calcium sitting on the top of his left coronary cusp there. And we measured that and found it to be 15 or so. And we were concerned about that. So we brought him to we do these in a hybrid OR. This was a case done under general anesthesia. We did a BAV with a 23 balloon and injected and saw coronary flow bilaterally, approximately equal coronary flow. And it's the usual coronary flow you see when you're rapidly pacing, which is not normal. But he had coronary flow, so we thought, okay, we'll put in the valve, not going to protect, which turned out to probably not be such a great decision. We put a 26 in, and it was a very uneventful case. Rapid recovery from pacing run. With the valve in place, he looked fine, no change in his LV function, a little PVL along the aortic mitral curtain, but nothing to write home about. Post-procedure course, he had a transient left bundle. We diuresed him. Echo the next morning showed a mean gradient of 10 across the valve. Again, moderate LV dysfunction, and ended up going to a sniff post-op day 4.
Do you routinely do an aortogram at the end of the procedure?
You know, we do for conscious sedation cases, Jeff, but typically not for if we've got a TE probe down and our hemodynamics are okay.
Okay. Sometimes it helps you if you're worried about coronary access and all that. It helps you at least know what you can tell your partners in the middle of the night.
Well, and I think we would do this a little differently this time. We did manipulate the valve a lot.
You had no concerns, right?
We weren't. I mean, we weren't concerned, but that was naive. And I tell you, our conclusion was, look, left ventricular function's fine, ST segments are fine, the guy hemodynamically is fine, transvalvular gradients look good, and we thought, okay, one of the many coronary takeoffs that you worry about, and frequently we protect. In this case, we didn't, but it seems that protecting means that you don't have to do anything and you pull everything out at the end of the case. So he goes to sniff, comes back on post-op day 7, chest discomfort, palpitations, he's in rapid AFib, gets cardioverted in the ER because he's hemodynamically unstable. He continues to have persistent and pretty marked ST depression on his electrocardiogram. Trope comes back at 3.5, so off to the cath lab we go. Here's his coronary angio. And I think, I don't know if you can appreciate it, but you guys may be able to see this on the dais because you have a bigger monitor, but you can actually see this kind of rock of calcium in the left cusp sitting up against the left main and really impinging on it. Here's his IVIS, and I apologize, I didn't have the capacity to edit this, so we're going to spend a few seconds here in the distal main, which is not particularly relevant, but some fibrocalcific plaque there, and a little bit of artifact now. This is the manual pullback, by the way. So, and as we come back, you'll really see that there isn't much to suggest that there's thrombus here. There's a little bit of, right there, you can see a little bit of fluttering there. That may just be flow in this externally impinged upon left main. But I didn't really get the sense that this was much about acute coronary syndromes as much as it was about rapid AFib and impingement on the left main. So we got a 3.5 DES, and with serial IVIS, we went back with 4.0 and 4.5 balloons. So is this a case of delayed coronary obstruction? You know, there's a little bit of literature on this, and it's clearly a rare event. I think this is probably immediate coronary obstruction that we didn't recognize. And I think we either should have done an aortogram so we could see the left main, or frankly, a coronary angiogram to see the left main. But for the purposes of the discussion, we did have a few risk factors in this setting. This is a very heavily calcified valve and calcium in the wrong places. And I think our device position was a little high. We manipulated the device a lot, and I don't know if you appreciated it during the deployment of the valve, but really we had pulled the wire back. We were on the inner curve of the aorta. We were a little tangential, and I think our valve positioning was slightly high. But my guess is this really isn't, look, I think from a clinical perspective, in a de facto way, is this delayed coronary obstruction? Sure. I mean, patient gets out of the hospital and comes back with coronary obstruction. But I think actually the coronary obstruction was probably there. We didn't do an angiogram at the end of the case, and I think we probably would have benefited from that, or he would have benefited from it. And I think probably this is demand ischemia more than anything with his rapid AFib. Does share some of the DCO characteristics of a high valve implant, marked calcium of the left coronary. As I said, this is a very low frequency event. In Jabor's paper, it's 0.22% overall, and others have described similarly low event rates. And I think actually in these data sets that we're acquiring, particularly with TVT registry, I think we're going to be able to look at this a little more objectively and figure this out. Thanks very much.
Yeah. I would just say, I'm not sure the height of your sapien, whether it be a little lower, is going to change that, right? You have open cells up there. That's a leaflet length calcification, because if you dropped it way low, you don't think that stiff thing's going to...
No, I would totally agree. And really, just trying to draw some parallels to what we're thinking about from the literature as DCO, I don't really think this was DCO. I think it was just uncovered at a later time because of clinical events.
I was going to bring my case was very similar one where we IVIS'd it, we protected it, we left. We thought that the leaflet was fairly away from it, a little bit. And so we left it. And while in the cath lab, she dropped the pressure, ST segments, and we stented it, and she did fine. But my point is, it's not very easy. This was an extreme case. But you can have intermediate case where you can have a leaflet which is close enough to the left main, but not quite inside of it, and you don't know what to do, and most of the time they do fine. So there is no real good reason to stent all of those. So
Well, we've had a couple cases where everything looks fine, patient is fine, but we can't pull the stent back because it's
not
partially
enough.
obstructed. It's partially obstructed and can be difficult to appreciate. Aortogram, even we put a guide catheter down and took a picture and we couldn't see it, but we knew that we had to fix it because...
No, the reason why it doesn't come out is because the STJ and S3 valve are close to each other. So if you measure the height, and if it's less than 16, the STJ, then it won't come out. So these days, what I do is I put a guide liner in all patients.
Right.
And instead of, if you're not 100% sure, you can put a balloon and then cross back from the S3. So at least the stent will be straight and not chimneyed, because this way the stent will be chimneyed. So those are but it's a controversial area.
But soon enough, you'll be splitting all these, and then...
That's right. That's right.
So my one question was that one important thing to know is that if you don't have sinus flow, so when you look at your coronary angiogram, you don't see any flow in the sinus. So if you don't see any flow in the sinus, this is a very high risk for thrombosis. So even though you didn't see thrombus, it's very possible that there was some thrombus in that area because there was no flow in the sinus. So if there's no flow in the sinus, this is an important thing because of the very large calcium. Otherwise, you should have some drainage in this sinus.
All right, we should move on. Will, that's great. Thanks, sir.